want to talk this hour about the experiences that you and the people working in the NHS, particularly in ambulance crews and accident and emergency departments, are having. The knock-on effect of the pressure on hospitals in A&E and ambulances trickles fairly quickly into a hospital as a whole and into community support as well as a whole. It doesn't take long before it's all hands on deck. But we haven't talked about the pressure very much, and apart from just, almost acknowledging it rather than really digging down into what it means for the delivery of healthcare, particularly in winter when there's an increase in those illnesses like flu and COVID, and although there was a COVID summer peak as well, wasn't there? But norovirus and RVS as well. It's a period of high pressure for the NHS typically. And then there's, we think of elderly people, we think of children, the most vulnerable, but any one of us can end up in A&E for any reason. We can fall over and break a bone, we can get appendicitis, who knows what it can be. We can be ill for any number of reasons. So this is something that I think clearly impacts on all of us. And if you do have, a very young child or an elderly relative who needs the hospital, it is an incredibly nerve-wracking experience if you go there and feel that you're about to enter the first circle of hell, because with the best will in the world, that's sometimes how it feels. And I was reading, I follow his Twitter reports very closely. Sean Linton, former Health Service Journal journalist and now Sunday Times health editor. He just put out a tweet the other day 2 days ago, saying, how's it going out there? What's the story on the ground kind of thing? And then people, either patients or staff who'd been in A&E or used an ambulance or worked in an ambulance service, reported back. And it does make very, informative reading, that's for sure. And I'm a little ashamed to say, and I'll say this because I think it's important that we do say truthfully how we feel about these things. I'm ashamed to say that yesterday when I was reading the responses to Sean's tweet, I was thinking, thank God I don't have to do that anymore with my elderly mother. Because we had, I'm going back 3, 4, 5, 6 years here now, I and my family, and she in particular, we had times in A&E and in hospital wards afterwards where it was just, people were doing their very, very best. But the experience sometimes was extremely difficult for everyone, including the staff. It's not about berating staff, this, far from it. And there was a time when my mum broke her hip or the top of her femur, and the ambulance crew that came were amazing, but they hated what they had to leave her in, which was a corridor, and the people keeping an eye on her in the corridor hated that she was in a corridor, and that when she was moved into an empty store cupboard for a bit of privacy and quiet, it felt like the Ritz to me and my sister who were with her. We felt, oh, thank God, we can close the door on it all. And that's not a healthcare system we should get used to or tolerate or be remotely satisfied with. It just isn't. And we know that the government is saying it's starting the process of bringing those waiting lists down and improving funding to the NHS, improving what it's able to do, as well as reform. And we'll talk about that, I'm sure, plenty throughout 2025. But I'm going to speak to two health professionals in just a second. I want to hear from you if you've been anywhere near an ambulance or A&E, either as a staff person or as a patient or a relative of a patient. I'd love to hear from you. How has it been? What was it like? 0345 6060 973, the usual number. Professor David Oliver joins me, an NHS consultant physician working hard at this time of year, and Phil Banfield, chair of the BMA as well. Professor David Oliver, first of all, you and I go way back in terms of our conversations on air, and you helped me on a number of occasions when I had questions around my mum's care. And you know, because you live it with your colleagues, you know that pressure. What's it been like?
Well, I think where I work, it would be the same as it is throughout the NHS, really, at the moment. You've got a kind of a perfect storm, really. First of all, we've lost a lot of general hospital beds over the past 30 years, so hospitals are running very hot and very full. There's big pressure to catch up on all of those delayed procedures, those elective cases. We've had a big surge of respiratory winter viruses, flu and COVID and RSV and norovirus, which is a vomiting virus. And then the other thing is, especially over the Christmas and New Year period, it can get harder to get patients back home again because we've got a lack of capacity and, delays in community health services, community social care services. And all of that, of course, will cause problems at the front door of the hospital because patients who need to be admitted to a bed often have no beds to be admitted to. On top of all of that, the staff themselves are under a lot of pressure and at risk of contracting infections themselves at work, and so you can get staff absences. I mean, this to an extent happens every year. And if you look at the figures for, say, flu or COVID or RSV, they're a bit down on last year. But if you look at the demand at the front door, it's gone up a bit. But it's a recurring cycle every year, and it's not just winter anymore. People talk about winter pressures. The reality is hospitals run very hot all year round, and we're very conscious as frontline staff that it's not an optimal environment for patients or the families to be in,
or indeed staff, because you will all be experiencing what I saw in that corridor and in that storeroom, and the staff don't like disappointing and letting down patients and watching them struggle either. Is it safe, David?
Well, the Royal College of Emergency Medicine have estimated that several thousand excess deaths a year because of overcrowding and long waits in emergency departments. Clearly, whilst lots of people can still get good care, there are safety risks about hospital-acquired infection, about rushed care, about missed care, about overcrowding, about patients in the wrong environment, and also about not just the urgent care cases, but the elective, the planned care that can end up being cancelled and delayed because of the lack of capacity. So there are very clear risks to patient care from those kind of pressures, no question about it.
So the answer really to my question is it's not safe for some people, as it turns out. Yeah. And is the reality, because you've seen it historically as well, is the reality that in a way, because we see these things, we as an ordinary citizens, we experience this almost as an individual, don't we? So unless it's touching our life, we just think, the hospital's bound to cope, they're bound to be able to care for people, until you go into it, particularly in A&E and ambulances queuing outside and people being treated in ambulance, and then you see a kind of, lowercase war zone.
Well, and I'm coming up to 36 years in the service, so I've been through good and bad times, but I think it's without making a party political point, it's important to emphasise to listeners that by 2010, 95% of people in emergency departments were being seen and discharged or admitted within 4 hours. We'd had pretty much eliminated 12-hour waits. We'd eliminated long waits for planned care. We're now hitting something like 70% for the 4-hour target. It didn't need to be like this. The service was performing pretty well. But a combination of underfunding of community services, loss of beds, staffing issues, population ageing and growth have caused that pressure. But I clearly remember a time when things were a lot better, and indeed both patient and staff satisfaction were higher because that performance was better.
Well, let's hope that means that can happen again. Thank you very much, Professor David Oliver, NHS consultant physician. Phil Banfield, chair of the BMA, joins me. Good afternoon to you.
Good afternoon.
Can it be improved again and fairly sharpish?
Oh, it absolutely can. We can't allow this national scandal to continue. But what happens is that we drip feed cash into where the sticking plasters are most needed, instead of tackling the underlying causes. We need to fix general practice. There's a conscious decision to underfund and not tackle the rising costs of general practice. So more people are presenting to hospitals. The vaccination rates this year are much lower. That puts more people at the front door. We had this situation this week where more than 50% of Welsh ambulances were queued outside of Welsh hospitals.
Well, they've declared a critical incident in the Welsh ambulance service, yeah.
Absolutely. And then we have this absolutely demoralizing state of affairs where you are having to examine patients clinically in waiting rooms and then put them back there. At any one point, we've got up to 20% of our beds occupied by people who should be somewhere else other than an acute hospital. So, social care needs to be provided in social care, not in the hospital system. But none of the four countries have a sustainable plan, and we've been talking about this for the last 15 years, and it beggars belief that we're still in this situation. So yes, it can be fixed. It can be fixed by joining it up.
And from what you've heard from Wes Streeting since he became Health and Social Care Secretary, and we'll come on to that last bit of his title in a moment, are you at least confident that he gets the idea?
Yeah, I'm absolutely convinced that he does understand that a government has a social responsibility to a national health service. I can't say that my experience with the last government gave me any confidence in that at all. It's now an issue of whether they can commit to getting everything right all the way through the system. There's no point in just piling money into hospitals. You've got to, yes, fund hospitals, but you've got to fund community care, general practice,
social care
to a proportionally greater
social care.
And you will get your money back.
Yeah.
This is an investment. This is not a cost.
Well, I mean, even in response to Sean Linton's tweet that I then pointed people to, I then started to get stories from people yesterday, or just last night actually, saying things like, my mum finally got out of hospital. Thank God, at least we're out, because she got an infection when she was in there, and she got norovirus when she was in there. It was hideous, la, la, la. But because there's no home carers available, social carers available, and she does need that extra care, she's had to go into an interim care home setting in order to... Now, that's good. Let's hope she gets back home and can get back home safely. But the dangers with all that toing and froing is that for an elderly person is that they lose their mojo in all of that, don't they? And they never get it back.
And they get confused. They become really disorientated, and that swings them back into the hospital system too readily. The continuity of care that is provided by general practice, cannot be overstated. It reduces hospital admissions, morbidity, and mortality.
And when it comes to that whole paradigm of hospitals, why have we so far been unable to shake that off? And I don't mean get rid of hospitals, clearly, they have the vital role to play. But why have we not yet been able to encircle hospitals with the sort of insulation of helping people so they never need to go there in the first place, other than when they absolutely need to go there?
Well, hospitals swallow cash. They overspend because of the need. That same investment is not put into preventative medicine. It's not put into the communities. Someone needs to be brave enough to say, to stop people going into hospital, we need extra and additional upfront funding.
In primary care and social care.
Because what happens when you don't do that is you've still got to treat the patients who pitch up at the front door. And, we are seeing the same patients time and time again, instead of spending and investing properly in keeping them out of hospital.
Thank you very much, Phil. Good to talk to you. Phil Banfield, Chair of the BMA. Just a reminder that the Welsh Ambulance Service overnight declared a critical incident because of the provision it is able to deliver to people. And we know that an NHS trust in the West Midlands in the Black Country has declared a critical incident as well, due to the number of people needing urgent and emergency hospital care, people being treated inside ambulances, which I am told has become a fairly common occurrence. I mean, once they get to the hospital being treated inside ambulances. It's not unusual for people to be treated in an ambulance at the site of the emergency or the pickup, but this is when they've arrived at the hospital, the staff coming out into the ambulances rather than there being room inside the hospital for the patients. What's your story? What's going on? And like I say, reading the responses to Sean's Twitter feed made my blood run cold from the memory and the trauma of doing it myself with family over the years. It really isn't. It really is no picnic. Quite the opposite. It feels like a war zone sometimes, and a very terrifying one.